Hello, I'm Neeraj Panchal. I'm an oral maxillofacial surgeon at the University of Pennsylvania. I've been a practicing oral and maxillofacial surgeon at the University of Pennsylvania for 9 years, focusing on a variety of areas, including nerve regeneration, trauma reconstruction, dental implant reconstruction, orthodontic surgery, among many other things. I have the distinct honor and privilege of doing our Generations in Regeneration podcast with Dr. John Zuniga today. Dr. John Zuniga was my former chair and former boss when I was a resident, and I want to give it up to Dr. Zuniga to introduce himself.
Thanks, Neeraj, and your only boss is your wife, and I hope you know that.
That's
My,
right.
my name is John Zuniga. I'm at Parkland Hospital, UT, Southwestern Children's Medical Center, and Presbyterian Hospitals in Dallas. I've been the chair of Oral Maxillofacial Surgery Division at those institutes from 2006 until 2020. Prior to that, I was at University of North Carolina Department of Oral and Maxillofacial Surgery at the School of Dentistry from 1986 to 2006. And prior to that, I guess I did my oral maxillofacial surgery training at the University of Rochester in Rochester, New York, as well as obtained my PhD in neurosciences. And I'm a graduate of Tufts University School of Dentistry. And it's a pleasure being here with Neeraj today.
All right, thank you, Dr. Zuniga. So, the topic of this podcast is generations of regeneration, and I'd love to hear from you, Dr. Zuniga, on, who were the people that really inspired you to pursue a career in academic OMFS, and what about them? What did they specifically do, and that really sort of ignited your interest in pursuing a career in academic oral maxillofacial surgery?
Well, thanks, Neeraj. I think that's a legitimate question based on what we're trying to accomplish today. And for me, as I just went through backwards my academic training in oral maxillofacial surgery, if we go back to the University of Rochester, what was unique about my experience there is that it was a program that allowed some individuals to do a dual program. Now, when you say dual program in OMFS today, you think of the MD. Back in 1978, there were very few dual degree MD programs, and there were a few dual degree PhD programs, and that's the program I was involved in. It was from the Eastman School of Dentistry, which was separate from the University of Rochester, but they're distinguished from the Dentist Scientist Award. The Eastman had an endowed program that supported postgraduate dentists in various disciplines, and oral maxillofacial surgery was one of them. And that program was run out of the University of Rochester at that time. So that was my opportunity. During that phase of my career, I chose to do a PhD program, and my primary goal was to learn how to be a scientist, because I always thought maybe I should have a good career in academics. And I'm glad I did, and that's what I have had. So who were my mentors at that time? I have to say that the mentor throughout my whole career has been my father. That's one, at every step of the way. But then there are individuals we meet on our journey or adventures or journeys. And at the University of Rochester, Bijan Aranpour was a primary mentor for me. And the reason is that Bijan had a particular strong interest in the PhD program and academic. He was a full-time academic individual, and he encouraged that. And he gave me some great insight into academic life in oral maxillofacial surgery. And then I met my advisors in my PhD program, and they are Shirley Joseph and Carl Carnegie. And basically, anyone who has done a master's or a PhD knows that you have to have a strong relationship between your advisor. And they, both of those individuals were strong supporters of my PhD work, and as well as directors. And they were not shy in telling me what I was doing wrong and what I did right. And that's very important. And then at the University of North Carolina, I think my mentors at that time were the UNC faculty and the colleagues in the Department of Oral and Maxillofacial Surgery. And a shout out to Tim Turvey, Ray White, Bill Terry, John Gregg, Myron Tucker. They were all excellent colleagues and as mentors, as well as being able to say, do what you want to do, what you have to do. And that was important. And then along my way, I did have an opportunity to develop an international relationship overseas, and I did a sabbatical with Ralph Evas in University of Vienna, and Ralph has been an excellent mentor for me even to these days. And then finally, at Parkland, I met the ultimate mentor of mentors, and that's R.V. Walker. I can't say enough about that gentleman and what he's done for oral maxillofacial surgery and myself. I'm sorry we lost RV in 2011, but I think that program still has his mentorship from afar. So and more importantly, RV was a gentleman and a visionary, and someone who understood the concept of leadership. And you know that he always used to say, "Do and be seen doing," and he lived those words, and he taught those words, and he passed them on. And so I feel it's my duty and honor to pass those words along, and I'm sure you are too, to these days. I think you're muted.
That's quite the number of prominent people in oral maxillofacial surgery that you were able to be mentored by. When you were being mentored by them, what did they specifically do and say and challenge you? Like, what were some specific things that were like, John, you need to step up your game, or what did they exactly say?
That's a good question, and I think my father had to do that every day of his time and my time, our time together. But if you think about building a career or advancing a career, I recall, especially my advisors, my research advisors, how they understood what tenure was. Very specifically, and what the rules and regulations, and it's just the advice they would give me is do things that you're best at. Go with your strengths. If you don't panic, and just keep rolling with your strength. If it works, it works. If it doesn't, it doesn't. And those are strong words even to this day. So that was particularly important. The other is, my father and even Bijan always used to say, have a 5-year goal and a 10-year plan. And what that basically means is that every 5 years, look ahead. See where you want to be. So when I was an young assistant professor at the University of North Carolina, I looked at what it took to be an associate professor, how long it took, what were their criteria, what did it mean to have tenure, what did that require, and I kind of placed that in 5-year goals to be realistic in achieving. But the 10-year goal was important, and that is, where do you see yourself at the end of all this? And that was important. My colleagues at the University of North Carolina allowed me to meet those criteria. I was able to go from assistant to full professor with tenure at the University of North Carolina, and I couldn't have done that without their support and understanding. At Parkland, I think, what can I say about RV? RV had came in at a desire to be a chair, to develop leadership skills and et cetera. And Neeraj, every day I walked into RV's office, and if we just talked about the weather or golf, I learned something. And just that the pleasure of his insight, his demeanor, his ability to move things along at a pace that's comfortable. Those are skills and abilities that not everyone gets to see. You get to measure the outcome, but how do you get there? And so that was those are some of the things that I learned from those gentlemen.
Earlier, you mentioned the topic of tenure, and for those people who are considering careers in academic OMS, now, and it's a sort of a different world now. There's, many faculty positions that are non-tenure track. There's many that are tenured track. There's more research-focused faculty opportunities. What are your thoughts on the young academician, especially someone in OMS, and how they should look at those things? Because I think that things have changed since your time, and I'd love to hear your insights on that.
Well, thank you for that question. I think that's asked of me almost every year during interview time. And I'll share a little bit of an insight you probably have already experienced, that when at your interview times, you have a lot of very, very ambitious young men and women who say they want to go into academics. One of the first things I ask them is, well, what do you know about tenure? And that's where it just stops, because unfortunately, I'm not sure the concept of tenure has been one, pervasive, two, respected, or three, passed on. My concept of tenure is it's a recognition by your peers for excellence in the areas of service and scholarly activity and even teaching. Excellence is defined by different institutes, but one of the commonalities for excellence is recognition by your peers, both locally, regionally, nationally, and maybe even internationally. So it's a form of recognition of excellence. And now, what does tenure mean to a academician? Well, several things at different times. For an assistant professor who is interested in tenure, it means work. It requires that you have an understanding that you have to develop and meet criteria of excellence in usually service and scholarly activity, at least scholarly activity, or education and service. So that means patient care, developing peer recognition for excellence in your clinical area. If it's education, it's developing excellence as an educator, be that teaching dental students, residents, fellows, other faculty in their discipline. When it comes to scholarly activity, excellence is defined differently at different institutes, but it's pretty much not just publication, but it does include publication, but it's grant allocation. Grants are usually funded through developing excellence in your area and having a plan to synthesize information for dissemination and advancement of that area. So grant allocation is also important for institutes because it's financial support for that institution. But tenure requires usually excellence in scholarly activity. So as an assistant professor, it means you're going to have to work towards that, depending on what your institute describes as meeting those criteria. But tenure is not just work. It also, in my opinion, is a bond, I'll use that word, a bond between the chair and that individual. Because a chair who's recruiting that individual is going to be judged at their success and the ability to bring tenure individuals into the department and into the university. So when a chair supports an individual for tenure, that chair is dedicating time, allowing that person to have the time and the effort to meet those success criteria. A chair who fails to do that, that individual is likely to fail, and that reflects the failure of the chair. So assistant at that level of assistant professor to the next level of tenure, which is either at the assistant to associate professor, or it has to be between the associate professor to the full professor. Tenure has to be defined. The risk of a tenure track failure is loss of employment at that institution. So if you fail to obtain tenure at the associate professor to full professor, deans will generally not allow that individual to progress, and that individual probably usually has to leave the institution. That's a risk. So the tenure has to be an important decision by the academic person, and as I say, a bond by that chair for that. Once tenure is granted, the positivity, if I can use that word, for tenure is somewhat of a job security. Each each tenured faculty has to undergo 5-year post-tenure renewal. So you don't get a free ride once you get tenure. You still have to be able to demonstrate productivity. But anyone who reaches tenure, they've learned how to be productive. So it's just continuation of that. Sorry for the long explanation, but I think it's an important question, and I think the elements of tenure are kind of lost in today's academic oral maxillofacial surgery.
Yeah, and you mentioned that about the element of tenure being lost. And what are your thoughts on the alternative career pathways now that are involved in quote unquote academic OMFS that are maybe more hospital based without a university affiliation, or potentially even a university affiliation that are just non-tenured positions as academic OMS?
Well, my feeling is that they're very important. They're not everyone should have be required to obtain tenure. There are universities are now having alternative tracks, and not only just educator track, but clinicians track. I think those are very important and very valuable positions. They are not second rate. I don't think anyone should consider those positions as second rate. The point is, however, that a tenure track is a committed track, and the individual who accepts that track and the chair who allows that to occur, they have to think very carefully. There's a lot more of a commitment for the chair to the faculty and for the faculty to the chair in a tenure position, in my opinion. You can reach excellence in clinical areas, which is very important. And the beauty of a non-tenure clinical track is that you can dedicate your time and effort to developing expertise in that one area, whatever areas that are clinical, without the pressure, I can use that word, of productivity in the scholarly activity, or maybe even in the teaching activity. So I think both the newly developed educators and the newly developed clinician tracks are extremely important. They're not second rate, and the individual. I'm glad those exist because they now allow individuals interested in academics to pursue their what they really truly desire.
You mentioned earlier on the folks who are on that tenure track of the importance of grant support. And when we look at our field as oral maxillofacial surgery, we have very few surgeon scientists, et cetera, that have significant grant support. Could you just comment on your experience with gaining grant support? What are some, thoughts that you can share with people who are looking for grant support, and from your experiences, and how to really build upon a funding mechanism for your career with grant support?
That's the primary reason I think I sought a PhD. Because within the realms of a PhD, the successful individual has to learn how to synthesize information, not just repeat it or advance it. It really truly is synthesizing. So that provides that individual thought processes on on looking at research questions and proposing research answers. Successful grant obtaining grants is kind of an art as well as a science. You have to learn the mechanisms of proper grant writing. Grantsmanship is what they call it. And success breeds success. So but in order to get success, you have to write the grants. So you need mentorship from individuals who have success in writing grants to teach you proper grantsmanship. That's why I go back to my my two research mentors, Carl Carnegie and Shirley Joseph. They really taught me how to synthesize information, how to put it down in scientific writing, and then subsequently how to write a grant or develop grantsmanship abilities. So developing grantsmanship ability is important. You need a mentor. You need ability to synthesize information, be a master of the area that you're interested, ask the correct research question in the correct way, develop scientific methods to analyze and and prepare the studies, and then once you're successful, start publishing. When developing a significant H factor, which is another value of your success and recognition. As you know, there are many grant funding sources. Besides the governmental, there's the Department of Defense, there's industry, and then there's foundations. And I think there's a lot of opportunities for oral maxillofacial surgeons to participate in all of those. You asked a good question as why, or you noted that, and I agree with you, that there seems to have been a diminishing number of oral maxillofacial surgeons who are successful in grant applications. That's somewhat true, and hopefully we're solving that. I think you and I have both seen an increase in foundations outside of the governmental and DoD. Osteosciences is a wonderful illustration of that. The Osteosciences Foundation is a great organization that really has been able to distribute funding for oral maxillofacial surgeons. I think that's very critical. AAOMS has its funding source through its foundation. That again is a wonderful contribution. And as oral maxillofacial surgeons, we should also look at non-OMFS funding sources through different foundations. The I'm associated with the Global Nerve Foundation has funding sources for oral maxillofacial surgeons. We should also look at other foundation opportunities outside of oral maxillofacial surgery. So I'm hoping that with proper mentorship, individuals who are interested in developing tenure tracks in their careers, those individuals will hopefully be guided appropriately to those funding sources. And I hope in the future we'll see more.
You mentioned the Nerve Foundation, the Global Nerve Foundation. Is that correct? Did I say it correctly? The global.
It's a Global Nerve Foundation, correct?
You mentioned that, and I know that you're intimately involved in that. And as one of the leaders in microneurosurgical repair of the trigeminal nerve, where do you see the next generation pushing the field forward? I know we've had talks about stem cells, and obviously, probably within the last 15 years, and you published on it, Dr. Malaro, Dr. Zaccardi, Dr. Myers have published on using the allograft nerve reconstructions that are available, and how that pushed things forward. What do you think is sort of the next area for trigeminal nerve repair and research in that field?
All right, good. Well, thanks for going right to where I'm trying this. I think there are several avenues. One is we're still diagnostically. We're still having challenges. Magnetic resonance neurography has certainly provided a significant improvement over our clinical neurosensory test modalities for many reasons. But unfortunately, it's not available to everyone yet. And part of it is radiologists, and part of it is institutions. I see that continuing to grow. I think as the quality and power of the imaging modalities, maybe even with combinations of ultrasound, we'll have chair-side abilities to properly, correctly diagnose peripheral nerve injuries, including the trigeminal nerve. That's one area. The second area is in reconstruction. I think the allograft materials with the allografts have really enhanced the ability to address these problems without creating injury to other nerves. Off-the-shelf stock grafting has made nerve repair, especially in our area, more acceptable, especially for mandibular pathology. I think that will continue. I think the challenge now is how can we make the current regenerative capabilities of these allografts better? And that's where we go into regenerative medicine. And at least in peripheral nerve, there are 4 areas that seem to be areas that should be explored. One is certainly factors, neurotroping, neurotrophic, neuropoietic growth factors are being tested in animals. Hopefully that'll bring us to the next avenue. The other is the ability to build scaffolds that are other than allograft. So conduit types of structures are being made in laboratories with scaffolds at the micro levels that simulate a peripheral nerve. similar to an allograft? Can they be developed so that there's guiding factors that can use combine with factors that'll guide nerve regeneration in a more efficient manner than we currently have? Electrical stimulation is another area of interest. There's several groups in Ohio and in Harvard that have looked at electrical stimulation as a regenerative natural process. What I've seen and read so far is that's very exciting. That natural electrical stimulation can, in fact, help sensory nerve regeneration. And then finally is immunomodulations and gene editing. There's a whole body of work with immunotherapies, immunodepressant drugs, immunomodulators, and even, again, gene editing to enhance nerve regeneration, what we currently have. So what I'm hoping is that in the next 15, 20 years, we'll continue to use allografts, but we also use them in combination with factors, with electrical stimulation, with gene editing, etc., to enhance peripheral nerve regeneration, and not just in peripheral, trigeminal, but in extremity, upper, lower, and in and prevention of pain is the last area of investigation.
Seems like you have many ideas for grants here.
Good.
Nerve regeneration. I wanted to give you an opportunity to ask any questions you had for me, Dr. Zuniga.
Well, I did, Neeraj, and I think one of the wonderful outcomes of having an academic career is you learn how to be a leader if you're successful, and define leader as kind of a good coach. So every year I get asked, well, what do you, Dr. Zuniga, want to see from a resident in your program? And I always tell them I'm looking for someone who's coachable. And I define coachable as someone, two factors. One, they're humble. Two, they're introspective. And the combination is important because someone who's humble and introspective is going to be able to learn from their environment and their mentors. Someone who's arrogant and extrospective will have a hard time learning, even if they're the best in their field. I take, for example, Michael Jordan, probably one of the best basketball players ever, but he couldn't win a championship until he had the right coach and the right environment colleagues. And to do that, he had to take it down a bit. He had to be humble, he had to be introspective, and that's what I look for in residents. And what I want that to have, the outcome, is I want that resident to become a coach. And so that's what I kind of see you doing. You're the next coach. And so my question to you is, what is your vision of an academic oral maxillofacial surgeon in 2024?
Yeah, so I recently read the article in JOMS about the academic OMS. That's the surgeon, that's the educator, that's the researcher, all in one. And like you, I agree that this new generation of academic OMS doesn't have to be pigeonholed to be that three-headed monster always. There's so many different opportunities in OMS, whether that's looking at health policy and being involved in health policy, whether that means doing administrative work within a hospital or within a department or within a school. There's opportunities for doing service work within the community or even abroad internationally. And so the definition of a successful academic OMS, I think, is very different from previous generations now. And I see that all across the country among the younger academicians. They're pursuing things that interest them. and they're not being pigeonholed into just being that, you know, and obviously it's a big ordeal to be the three-part surgeon, where academic surgeon, where you're doing research, you're doing teaching, you're doing surgery at the same time, and building that clinical reputation. And so, you know, I think our specialty has to continue to move forward, and allowing people to pursue the interests, that they have, and still be part of an academic university environment. And I think not all of us can be, you know, the researcher, and can be the educator, and can be the surgeon operating in the operating room 5 days a week. You can't be everything, and I think we have to sort of understand people's limitations, and also, you know, keep in mind that you know, people have lives outside of OMS, and you know, we want people who have character, that, you know, have good, strong family values, leading our specialty as well. And so, you know, my view on that is you know, we need to start looking beyond just the classic nature of what an OMS academician is. The other thing I think, second part is that we need to engage more folks who are not OMS to join our field to do research in OMFS focused areas, and whether, you know, it's bringing in researchers that are engineers, that are stem cell biologists, into our field, and make them a part of our field, and to do research in areas that we're interested in, whether it's nerve regeneration, or research on an ameloblastoma. You know, I feel like many of our academic OMS programs across the country are doing wonderful and excellent clinical work, but not engaging scientists, and being collaborative with, you know, PhDs, and engineers, et cetera, in pushing our field forward. And I think we, you know, if I had a criticism of our specialty, that's one of them, that we need to engage other folks, and bring them into our specialty. And really, I think it'll advance us, because as someone who tries to be that maybe three or maybe four-headed surgeon, where I do administrative work, I do research. Just today was funded by the NIH with one of my collaborators, which was exciting. So it's a good day. You know, doing surgery, and educating residents and students. You know, it's a lot of work, and you know, there may be folks that are not interested in that, and I think as a field, we need to make sure that we include people with, and support their various interests. The other aspect that I think is really critical that folks don't talk about in academic OMS is the financial aspect, and you know, our debt load for our graduates. I mean, I have some residents graduating with over $1 million in debt. And you know, there is a significant salary difference that exists between academic OMS and private practice OMS that's well known. And you know, when you have $1 million in debt, you know, it's a pretty big, hefty load. And I think as a profession, I was fortunate enough to be you know, supported by AOMS and the FIDO award. I was also fortunate to be supported by the AOMS OMS Foundation on the getting a foundation grant. You know, we need to have more of that, to, you know, help support you know, OMS in their academic careers. And you know, my hope is that we can find other funding sources for our specialty, and to help support it. You know, and I think many of the leaders of our specialty right now are have a lot of passion for our specialty, and hopefully they'll be able to bring passion and bring in donors into our specialty as well, to support young academicians, and so they can pursue and push our specialty forward.
Well, that's great, Neeraj. I think our profession is in good hands with young people like yourself. Thank you.
Thank you, Dr. Zuniga. Well, I wanted to just thank Dr. Zuniga and thank the OsteoScience Foundation for having us today. And you know, obviously, Dr. Zuniga and I are both open to questions from, you know, anyone. So feel free. You can email me. My email is npanchal@upenn.edu. That's npanchal@upenn.edu. And Dr. Zuniga, I think I remember it, but I'll let you.
It's john.zuniga@utsouthwestern.edu.
I think I was correct. Thank you, Dr. Zuniga, and thank you to the Osteoscience Foundation.
Thank you both.
To learn more about Osteoscience Foundation, visit osteoscience.org or follow us on Instagram, Facebook, and LinkedIn.